hand it over to Dr. Srinath Balakrishnan, who will be the host for the session. He is a professor at IIT Goa.
Okay, good afternoon, everyone. So I warmly welcome you, everybody, to this webinar, which is being jointly organized by NCBS and IIT Goa. And today we have very eminent people to talk and discuss about something which is affecting all of us a lot. So we have first talk by Professor Shekhar Mande, who is a computational structural and computational biologist, and he's also the Director General of CSIR. Okay, so first thing is I would not tell all of their achievements, because if I do that, I would probably take the entire time for just saying that. So I would just say very brief introduction for all the eminent people here. And then, so he's going to talk about his work, which he has jointly.
Yes, I think both Rajiv and I will just introduce ourselves and start. That's better.
Okay, sure, no problem. Yeah.
So currently I work at CSIR New Delhi, and before coming to CSIR, I was at National Center for Cell Science in Pune for 7 years, and my PhD is in molecular biophysics. So I don't claim to understand biology that well. We have worked on peripheral problems in biology over the years, but one of them is this one that we are excited with. And Rajiv can also introduce himself a little bit.
Yeah. So I am a mathematician, statistician who is interested in anywhere where mathematics and statistics is used or applied, and that's how I got involved in this aspect. So I think that's enough for today. Yeah, I'm professor and director at CMI. Yeah.
And every 5 years you would see Rajiv hyperactive on TV, telling the results of elections and predictions of the psychology and everything.
Okay, so I think then I'll let Professor Gautam Menon and Gandini also to introduce themselves, I guess.
I'm Gautam Menon. I'm in physics and biology at Ashoka University. I'm a modeler by practice, so I think about mathematical models, and I'm particularly interested right now, as all of us are, in infectious diseases.
I'm Gagandeep Kang, and I think I can lay claim to having the greatest interest in infectious diseases because I've spent the last 30 plus years working on infectious diseases, mostly at CMC Vellore.
Okay. Thank you very much to all the people who we're going to have a good time talking about this. And I would now like to give it over to Professor Shekhar Mande to give the presentation on his the new work that they have done on the hygiene hypothesis and COVID-19 in India. It's Professor Mande, so over to you.
Thank you, Srinath. On a serious note, you should also get Rajiv sometime talking about the science behind election result prediction. It's very, very fascinating. What he actually does, the sampling, and what kind of sample size is necessary to predict election results. And his has been, of course, always the most accurate of all the results. And he will tell you the success behind the election prediction at some point of time, maybe some other day.
Sure, we'll do that. Yeah, definitely.
So Rajiv and I, we actually collaborated on this particular work. And the work is getting published in the 10th February issue of Current Science. And the title of the work is Mortality Due to COVID-19 in Different Nations is Associated with the Demographic Character of Nations and Prevalence of Autoimmunity. We had submitted the work to a few other journals before we eventually made it in Current Science. And the title was much more provocative. There it actually said that it also relates to hygiene hypothesis. But most people found it so provocative that we had to eventually drop that particular thing from the title. And our interest actually began with the observation that COVID-19 mortality has exhibited a wide range of variability across different nations. And if you look at today, it's quite amazing actually. If you look at the number of infections and number of deaths across different countries, let us just take an example of US. US is 1/4 the population of India, right? And the total number of people who have died of COVID-19 in US is 2.5 times that of India on today's date. And it is huge. If you come to UK, there's even more stark, right? UK is about 1/20th population of India. UK's population is about 65-68 million on today's date versus 1.35 billion of India, right? I mean, that's the population number. Today, India has reported mortality of about 150,000, 1.5 lakh, while UK is closing on to 100,000. Now, this is very hard to explain that why the different number of people are dying in different countries like that. And if you look at in general that the mortality rate, what is also called as number of people dying per million people, there's a clear trend that this appears to be a disease of the rich nations. You know, I mean, in the rich countries, more number of people are dying than in the poorer countries. And that was a bit confounding because you would have thought it's an infectious disease, it's a virus, and therefore, as it sweeps across humanity, people in the poorer countries would be affected badly because of variety of different reasons. And exactly contrary has happened in this particular case. And therefore, what we decided that we should actually look at certain parameters and try to reconcile ourselves to what the parameters tell us. So we picked up publicly available data from 106 countries on parameters such as demography, prevalence of different diseases, both communicable and non-communicable. People have talked about BCG vaccination correlation with COVID-19.
Just a moment, Professor Mande. Did you move the slide, or because I don't think the slides are moving for us? Here it is not moving.
I'm on the second slide. The title is mortality due to COVID-19.
No, no. We are still on the first slide. Yeah.
Showing on this.
Oh yeah. Now it's fine. Yeah.
Okay.
I will not go into the slideshow mode. I will just be like this.
Sure. Okay, no problem. Yeah.
But then I have some people here who are not able to see these slides.
No, now we are able to see the second slide. Now we are on the second slide.
Okay. So I'm not going on the slideshow mode. I will just remain on this particular mode.
Sure.
That's fine. Yeah.
Yes. So we actually looked at many different parameters like demography. It was known from the very beginning that people who are aged, especially those who are above the age of 65, are more susceptible. In fact, more number of people who are above the age of 65 were dying, and so on and so forth. This was known when we actually started our work. And our major findings are just put in 3 bulleted points, but I will come to them one by one. Now, let us look at these cases and the deaths across the world. This is data sometimes in August. It's taken from WHO website. How many cases per million population? And if you look at the data here, you see that US and Brazil and Chile and countries like that are a bit more affected than other nations, right? I mean, Africa or Europe or something. But what you don't see is as much contrast as you go to deaths per million. The moment you go to deaths per million, look at this. I mean, if I superimpose these 2 figures, look at this. And the contrast now becomes obvious. How many people are dying per million? Look at the contrast between Eastern Europe and Western Europe, the former Soviet bloc countries and the Western Europe. Look at the contrast between African nations and US. And look at the contrast between Southeast Asian nations and rest of the world. It's just remarkable that many more people in the developed world or high GDP countries appear to be dying than those in the low GDP countries. Right? I mean, that's the observation and it's a fact. Now, obvious reasons for this, and many people actually criticize when we started, we publicize our work, saying that it's obvious that many countries are underreporting cases. Right? I mean, there's a common criticism that came from everyone. Now, if you get to underreport, for example, let us just take a test case of India. You know, as I told you, India's population is 4 times that of US, and we have reported 2.5 times less number of cases in India. So if you get the ratio right, and if India were to be underreporting, on today's date, 150,000 people in India have died. If the ratio were right, 1.5 million people in India could have died, right? And no public health expert would accept the fact that India has had 1.5 million people dying of COVID-19 on today's date. All the cremation houses and everywhere would have been full of dead bodies by now. So obviously, underreporting is not the case. Under-testing may be the case in many countries, but under-reporting is a kind of reason that we would like to allude to if you don't want to accept the fact that this is the fact that many more people in the rich countries are dying than in the poor countries. That is the fact that stands even today. Okay? And that's actually very fascinating to explore. Why is that? Now, if you look at the daily COVID-19 cases in some of the countries even today, This data is 2 days old, and mind you, the y-axis is very different here. So put in the context the scale of the y-axis. The US y-axis is up to 300,000, Indian y-axis is up to 100,000, and the UK y-axis is 80,000. So remember, UK population is 1/20th of India's population, right? And yet the y-axis is something very similar. On the other hand, countries such as Morocco or Thailand, look at the y-axis, 1,500, 6,000, and so on and so forth. So the total number of cases in the countries which are poor obviously is way lesser than the other one. So there are obviously some other scientific reasons behind it. Maybe we have predetermined immunity. Maybe in some of the countries where SARS-CoV-1 had been an epidemic in the past, maybe those antibodies are protecting us, or maybe there are some other reasons. And these are the reasons that actually would be very fascinating to explore. Now, just to give you numbers, a feel for numbers, that how many cases per million have happened in most of the world. I have not shown here a country called San Marino. San Marino is a country whose population is about 300,000 and has the maximum rate of people who have died in San Marino. It's one of the wealthiest countries around the world, but also is a country where many of the old people would like to go and settle down. And we know that the mortality has affected people above the age of 65 more than those of others. But even here, look at the contrast. In Thailand, 1 person per million has died. In Belgium, is 1,800 people per million have died. And look at the contrast between India and Morocco. In India is about 111. On the other hand, Belgium is 1,800. UK is 1,500. US is 1,300. And there is no fudging of data here. Despite all the criticism that we may receive from all over, trust me, there is not much fudging of the data. If any underreporting of anything is there, it's not going to make up of a ratio of 1:100 in such a case, or 1:10 in such a case. That let us be very clear about it. So this is the rate. This is the reason that actually we started exploring. So when we started exploring, we thought that first thing we should look at is prevalence of different diseases in different countries. Now what I show you here in the blue are the non-communicable diseases. In orange are the communicable diseases, and in the gray there are other factors such as accidents and things like that, what people are dying in different countries. And all of us know that most of the high human development index countries, which also happens to be high GDP countries, the disease profile has distinctly moved in the last 30 years to those who are dying of non-communicable diseases rather than communicable diseases. This is the last 30 years of development at what we have seen. In most of the high HDI countries, people are dying because of non-communicable disorders, right? Whether it be cancer or diabetes, or they have very high prevalence of allergic reactions or high prevalence of autoimmune disorders. This is all very distinct in high HDI countries. Well, in low HDI countries, there's still very high prevalence of communicable disorders, tuberculosis, malaria, filariasis. All of these are much more prevalent. Cholera, they are much more prevalent in the low HDI countries. And what you see here, actually, in the panel, the top left is India, the top middle is Thailand, the top right is United States, top bottom is Morocco. I wanted to give an example from Africa, so Morocco, and then top middle is Belgium, bottom middle is Belgium, and bottom right is UK. There's the profile in different countries that you see, and distinctly countries which have high HDI, such as US, UK, and Belgium, there's the top right, bottom middle, and bottom right. You see a dominance of blue color there. But in other places, India, Morocco, and Thailand, you see dominance of orange color even now. And that has happened principally because in the high HDI countries, over the years, things have become highly sanitized. So sanitation conditions, access to clean drinking water, access to no open defecation, all these things, high HDI countries have actually gotten rid of in last 30, 40, 50 years. While the low HDI countries, there is still prevalence of access to clean water, potable water, and so on and so forth. Now that is a very distinct shift that has happened in the last 30 years, 30, 40 years, because of the disease prevalence that you see very, very clearly. So sanitation is a very clear parameter, or access to clean drinking water is a very clear parameter for communicable diseases. We don't have to say that, it's an obvious thing, right? I mean, all communicable diseases this is a very important parameter to consider. But because of very high hygiene in high LTI countries, there have also been papers now in literature which state that that has led to high incidence of allergy, high incidence of autoimmune disorders in the countries such as UK, US, and Belgium, what is shown here. So hygiene has also been correlated or attempted to be correlated to allergic reactions and things like autoimmune disorders. In fact, there have been cases that we know of that people who lived in countries such as Switzerland, I mean, at least I know one case myself, but I've also heard of many different cases who had autoimmune reaction when these people were living in Europe. Doctors advise that you are living in a clean environment. You rather need to go to an environment which is not as clean so that you will not get a very severe autoimmune reaction. And those people, when they move back to India, they actually live very healthy lifestyle after coming here. That's a very clear correlation to health and autoimmune disorders or allergy. You know, I mean, that's a correlation that maybe Gandini would like to say a little bit towards the end of this thing. Now, when we look at, once again, the prevalence, now this is the raw data, so it's very noisy, but the correlation is very noticeable here. What I show on the left-hand side graph is the communicable diseases, and what is shown in purple is tuberculosis. On the x-axis is log of GDP, on the y-axis is the prevalence of communicable diseases. So you clearly see a negative slope if you were to fit in a line there, that log of GDP, high GDP countries, there is less tuberculosis. In low GDP countries, there is more tuberculosis. On the other hand, if you go to the right-hand side, you see the urbanization in high GDP countries. The blue graph is urbanization, and obviously in high GDP countries, there's much more urbanization than in the low GDP countries. So most of the population is moving from rural areas to urban areas, which is also happening in the last 30-40 years also in countries like India. But the correlation is unmistakable, although the graphs are noisy. So let us not worry too much about the graph. Let us just remember there is a correlation. Now let us come to COVID-19. You know, why people are dying of COVID-19. Now let us look at this particular aspect. And I'm giving this particular graph for any viral infection in general. There are exceptions. So for example, HIV is an exception, and we'll not talk of HIV. But let us say flu as a influenza as a common example of a viral disease. Typically what happens is that what you see here as a bell-shaped curve in the middle is the viral load starts actually going up from roughly about the third day when you are exposed to the virus. And the viral load goes up dramatically, exponentially. It plateaus down, and by something like 7th or 10th day, the viral load in the body starts coming down dramatically. That's where you get actually the bell-shaped curve. And that happens in most of the viruses, whether it be enteric viruses, whether it be flu, and others. As I said, HIV is an exception, so let us not talk of HIV. But most of the viruses are like this, and COVID-19 is no exception to this particular one. The cellular response actually sets in on about 7th or 8th day. But what happens is very important is the IgM response. That also is the onset is on about 8th day, and the IgM response actually starts coming down by something like 13th or 14th day. But then you talk about IgM to IgG switch. By then IgGs have taken over, and then you get actually long-lasting immunity in many cases, which actually sets in, and you generate antibodies which are long-lasting in most cases from the 14th day on. That's the IgG. So that's actually what you see here in purple is the IgG response. Next to the purple line is the black line, that is the IgM response, and the bell-shaped curve is the virus. So virus is actually gotten rid of very early on. Now COVID-19 has another peculiarity, and let us look at COVID-19. What actually happens as a chronology of SARS-CoV-2 virus. So on the top left, what you see are a number of cells which are there. One of the cells is infected with SARS-CoV-2. The virus is internalized, as all of us know, by receptors such as ACE2 and TMPRS2. So these are the kind of receptors through which virus binds to the cell surface, and then is endocytosed. As soon as the virus is endocytosed, and the viral RNA then becomes exposed for replication by the RNA-dependent RNA polymerase, at that stage, the infected cells, they secrete things like ATP, viral RNA, viral DNA, and so on and so forth. So the infected cells themselves actually secrete some of the secondary messengers outside. And these secondary messengers have an effect that they attract a whole lot of co-stimulatory molecules or also cytokines and all to them. They attract things like monocytes, they attract things like TNF alpha and so on and so forth. And with that, actually, all these cytokines and all eventually also attack the neighboring cells. Not only the infected cell, but they also start having an effect on the neighboring cells that is shown at the bottom left panel. Right? On the other hand, people who are rather healthy or those who actually don't have this hyperimmune kind of a reaction, they don't have actually many cytokines attracting to the infected cells, they actually behave as if the bottom right panel. That the cells which are infected, they actually try to get rid of the virus, and antibodies which are generated, they also actually bind to this virus and eventually get rid of the virus, so viral load comes down, and you don't actually see the kind of cytokine storm that you see on the bottom left panel. Right? So what actually happens is that you don't get a hyperimmune reaction as what you see on the bottom left, as in the healthy individuals or the individuals who don't hyperreact to the virus, as you see in the bottom right. So these are actually very distinct characters between two kinds of people: those who have this very bad cytokine storm and those who don't. That's the kind of thing that what we have. So in our analysis, we considered all these different parameters, and we took the statistical data from most of the well-known sites, such as WHO, from the global health data, from World Bank, and so on and so forth. The human development parameters and all we took from World Bank. Many of the disease prevalence things we took from WHO. And then we actually did an analysis where we tried to correlate each of these parameters to log of deaths per million. So we have taken tropical diseases, such as that shown in pink: schistosomiasis, lymphatic filariasis, ascaris, hookworm, malaria, and so on and so forth. We took autoimmune disorders, such as rheumatoid arthritis, some of the allergic reactions, and so on and so forth. We took developmental parameters such as log of GDP, human development index of each of the countries. We looked at demographics. There's a population of about 65 years of age, obesity, urban population, and so on and so forth. And we also looked at sanitation, that is access to hand wash facilities, access to basic drinking water, and so on and so forth. So number of parameters we took, and the first obvious thing that we had to do was to calculate correlation coefficient of each of these one against another. So we calculated the Pearson correlation coefficient of all versus all. Now we should remember that different countries had onset of the disease at different dates. For example, we know that in China, the first of the cases was reported in literature on 30th December 2019. Although the disease was there already, but a cluster of pneumonia cases, pneumonia-like symptoms, were observed on 30th December. WHO was alerted, and by 7th January 2020, we knew that it is SARS-CoV-2 in China, in Wuhan province. The first of the cases in US was reported sometime around 20th January. The first of the cases in India was reported on 30th January. But different countries reported cases at different times. And therefore, to normalize, we have to make sure that we take also the start date of diseases in different countries. So we have taken the data from the beginning itself, beginning of the pandemic, but also in the first 60 days, first 90 days, first 120 days. And then we did linear regression of all the parameters together, and also Pearson correlation coefficient. So I don't have to go into what linear regression is. This is simply the data. On the x-axis is countries with high GDP. As you go from low GDP to high GDP, there's the x-axis, and you clearly see that there is a linear kind of a relationship between GDP and the number of people who are infected. As on 29th June, disregarding what is the start date, and this is on the 60 days. If you look at, if you take into consideration the start date, in both the cases, you actually see a straight line that high GDP countries have higher number of people who are either affected or dying. And this is one of the most important figures in our paper, all versus all Pearson correlation coefficient. What you see, we have plotted. You'll not be able to read this, but you can just appreciate log of GDP, high human development index, age above 65 years, and so on and so forth. You see a clear distinction, anti-correlation between things like access to hand wash, basic drinking water, basic sanitation, and all, and tropical diseases. What you see there in center, the red dots, are actually a clear negative correlation of that, and that's very well known. Public health experts all around the world know that improved sanitation reduces the impact on tropical diseases. What you also see is a positive correlation between improved sanitation and improved autoimmune, improved allergic diseases, and that is shown in blue dots in the center. I mean, that's the kind of correlations that we see and which are all well known. We are not discovering anything new here. But what we are discovering now is the regression between different parameters. So we start from the top is the demographics. In the center top is sanitation. The top right is autoimmune diseases. The bottom right is demographic and sanitation. The bottom middle is sanitation and autoimmune. And bottom right is demographic, sanitation, and autoimmune disease. And what you clearly see here is a straight line and the best correlation when we combine demographics, sanitation, and autoimmune disorder prevalence in that. And that's actually very unmistakable, this particular correlation. And to get the feel for the numbers, these are the numbers that you see. And the most important numbers are at the bottom in the table. If you look at the autoimmune disorders, the multiple sclerosis, rheumatoid arthritis, asthma, psoriasis, and type 1 diabetes, the adjusted R square is about 0.5, 0.46, and the log of deaths per million, the correlation coefficient R is about 0.7, and that is unmistakable, and that is 60 days after the onset of diseases. But even after 120 days, the correlation does not vanish. I mean, it still remains quite significant in that particular respect. And when we actually do a combination of all the parameters, once again, the bottom one is the most important one, that is demographic, sanitation, and autoimmune diseases. You see that even after 120 days from the onset of the disease, you have an R of 0.7 and adjusted R square is about 0.42, and it is fairly significant. So what it seems to suggest is that demographics of nation, the sanitation parameter, and the incidence of autoimmune diseases clearly seem to have correlation on how people are dying of COVID-19. And that brings me to the final two slides of my talk and our hypothesis. And that's where actually the hygiene hypothesis comes into play, because we are talking of sanitation and everything. And hygiene hypothesis actually begins with the fact that in countries which have low human development index, from childhood, from the very fact that the child is born, the child is exposed to many different viruses, bacteria, fungi in the environment. And those people who survive all of this and grow up, their immunity is actually very well trained. And therefore, in future, when they are confronted with diseases, especially infectious diseases, they react better, their immunity reacts better to those infectious diseases. While in other countries in which people are not exposed for such diseases from childhood, their immunity is not very well trained, you know. And that observation has been made from the first line, which is not readable here, but I will read it out for you. It says, the increase of allergic diseases in the industrialized world has often been explained by a decline in infections during childhood. Remember, that's the thing that hygiene hypothesis actually starts with. But the core of it is essentially is the immunologists would like to say the balance between TH1 and TH2. I mean, that's my second point that I'm coming to. How the balance in TH1 and TH2 is actually achieved is the core of how COVID-19 is dealt with. Now, all of you are aware, TH1 response you get primarily for infections as viruses or for bacterial diseases and all, while TH2 response you would get for helminths and for some of the allergic disorders and all. And that's the key of control of COVID and how people are dying during COVID-19. That's the real key. And that actually explains why more people are dying in the industrialized world and why less people are dying in the countries such as Africa or in the South Asia or Southeast Asian subcontinent. And that is actually captured in this particular slide. Once again, it comes back to hygiene hypothesis. On the left-hand side, if you have high hygiene and low pathogen or adjuvant burden, your dendritic cells are not as well trained. And what you get actually is you actually don't get a proper balance between TH1 and TH2. And because of the loss of balance between TH1 and TH2, in absence of regulatory T cells, your immune system actually is not very well trained, and you get an hyperimmune reaction. And a hyperimmune reaction essentially is what you get your cytokine storm. The cytokine storm that we have been actually talking about in COVID-19 is essentially because of that. And that leads to eventually the pneumonic symptoms in the patients. And of course, people then die of whatever, loss of oxygen or whatever. On the other hand, low hygiene conditions and high pathogen adjuvant burden, your dendritic cells are educated, your immune system is educated, and dendritic cells can develop into distinct subpopulations depending on the nature that they receive signals from the microenvironment. And the T-Rex get trained, and the balance between TH1 and TH2 by any that is, and therefore regulatory network ensures that the immune system does not react in a hyper manner the way it ought not to react. And therefore you actually don't see immunopathology the way you see in the industrial. That essentially is the basis of this particular one. So I just like to mention anecdotal incidents. There were people who were expecting in March last year, very, very distinguished people. People who have working in Johns Hopkins University, people who are working in some of the most advanced or well-known universities around the world. They had anticipated 300 million Indian infections. Trust me, there is a paper which claimed that in no time India would reach the number 300 million. You know what is today's number? Is 10 million. It's unbelievable. When the disease was reaching Dharavi, all of us, including everyone in this room or those who have joined on the webinar today, we held our breath. We did not want a catastrophe. All of us were fearing a catastrophic reaction when it reached Dharavi. What happened? How many deaths in Dharavi? Hardly any. I mean, unfortunate deaths, but they did not cross 1,000. We were expecting catastrophe. And that can only be explained by one parameter, hygiene. You know, and that's the hypothesis that what we have proposed is that this is by far one of the best examples of hygiene hypothesis working here. However provocative it may sound to the scientific world, but we firmly believe there's the low hygiene conditions which have worked in our favor, at least in this particular incident. Thank you all very much.
Okay, thank you, Professor Mande, for that very forceful talk, and he has championed his cause very well. And I would first like to have some views from the other panelists who are not part of this work. So first, I would like to invite Professor Gautam Menon to talk a little bit about what he thinks about this work, and then I would next ask Professor Gandini also. First, let's Professor Gautam Menon, please go ahead.
Thanks, Srinath. Can I share my screen? I think for that, Shekhar has to stop sharing his screen.
Okay, yeah, sure. Professor Mande, can you please? Okay, yeah, it's unshared now.
Yeah, I had some slides to show.
Sure.
Let me just locate them.
Yeah.
Yeah, can you see my screen?
Yes, we can see that. Yeah.
So it's a very interesting and provocative hypothesis. I don't think it's completely new, but I think the extent to which Shekhar and Rajeeva have really done this very extensive study across the 105 countries, that is unusual. There's a very large number of variables. What I want to do is to sort of describe some delicacies in the argument and put it in a little more general context. So this class of arguments is called, this class of correlations between, let's say, bad hygiene and certain health consequences, is an example of what is called an ecological correlation. It functions at the level of countries as a whole, large units of people. So let me give you one example of a case where ecological correlations can be wrong, just to illustrate my point. That's the example of if you take 1,000 men and 1,000 women who apply to a university. The university admits 840 men and 780 women. So the inference from this might be naturally that the university is discriminating against women because it has taken more men than women, although equal numbers of them have applied. Okay, so this is an example of a correlation or an inference that you can draw from looking at large aggregates, large numbers of people. In the next slide, let me give you a little more detail. So it's, as I said, it admitted 840 men and 780 women across all the departments. But there's a slight difference in the departments that men and women apply to. The men took the easy way out. They applied to Department A, which was easy to get into, and relatively smaller numbers of women did. 900 of the men applied to Department A, while only 700 of the women applied to Department A. For Department B, only 100 of the men applied to Department B, while 300 of the women did. And Department B is a competitive department, it's hard to get into. Department A is an easy department, grades are easy, and it's easy to get into. If you now look at the proportion of males to females across each department, in Department A, the proportion of males is 0.91, females is 0.97. In Department B, it's 0.2 is males and 0.33 is females. So at the level of each department individually admits a larger proportion of women, even though taken together, the university seems to have taken more men than women. Not seems to have, it's actually taken more men than women. That's because of a confounding variable. More women apply to the more selective and harder departments than men. And this may look like an artificial example, but it's actually a true example. It comes from the University of Berkeley in the 70s, which actually was faced with a lawsuit and much discussion around an issue where the numbers are made up here, but the arguments are the same. So this is just goes to illustrate that any association at the level of populations, large groups of people, can be completely reversed within subgroups comprising that population. What may be true for the large group may not be true for the individual. This is called the famous paradox called Simpsons Paradox. And establishing causal links become that much more harder because you're sort of imagining that what is true at the level of large associations of groups must also hold at the level of individuals. This leads on to something called the ecological fallacy, which really is related to that. And that is the fallacy of thinking that relationships for large groups, for example, nations, necessarily hold for individuals or even smaller groups. I'm just saying that this class of arguments, which looks really at large nations as a whole and tries to establish correlations or links between them, it's not that it has to be wrong, but one has to investigate it at a more local, granular level to actually ask if it makes sense, if it holds up. That was just a general comment about this class of arguments. And of course, as Shekhar pointed out, there are other ecological correlations. BCG vaccines was one, and then it was argued that countries which had administered vaccines over many years were in a sense protected better than those who had not. For example, much of the industrialized West, North America, Canada, etc., don't have a BCG vaccination compulsory program. Environmental pollution, countrywide measure of environmental pollution, are also ecological correlations that have been linked to COVID-19. Buddhism, a sort of good fraction of the countries which report small numbers of deaths per million population turn out to be Buddhist countries, Laos and Vietnam, etc., with a substantial fraction of the Buddhist population. Some of these we take seriously, some of these we don't. And of course, one needs to dig in deeper into the data to find out what is it? Are these real correlations? For example, BCG might have worked, but one has to check and see whether it actually works. The second point I want to make is what is India and what is the nature of the Indian number? And here I want to point out that there is a very large variation of deaths per million, even look at smaller groups in India. And part of this is related to undercounting. And I think any reasonable measure of undercounting, for example, I think although we record about 80% of our deaths, a medically certified death, medical certification of causes of death, MCCD, is only available for about 22% of deaths in the country. If you look at these cities, so this is India's 25 largest urban areas. This is deaths per million, Mumbai, Delhi, Kolkata. And this is a little approximate, but you get the idea of what this. There are large numbers and there are small numbers. And among the larger numbers, 750, etc., 750, 780, 800, etc., undercounting of a factor of 2 pushes you into the territory of the UK, Brazil, and the US. And that's not an unreasonable undercounting. So again, here, when we talk about India, we marvel at the small Indian number of about 120, 130 deaths per million. But it's important to remember that there's much more complexity and structure inside there, and to keep that in mind. Here's some sort of mysterious data that just sort of tells you the complexities of thinking about this. And these are 2 surveys conducted in Karnataka. One is a CPHS survey, which is between sort of July and August of last year. And this survey concluded, it's a set of survey that concluded about 46.7% of Karnataka had been infected by that time. And the same data set was used to sort of infer that there must have been a large number of excess deaths. and an IFR, infection fatality ratio of about 1.3% as an upper bound was obtained from the same data set. A slightly later survey from the Department of Health and Family Welfare of Karnataka, so later by about a month and a half, found that only about 27% of people had been infected in that survey, and the IFR was 0.05%. That was their number. You can look at this huge gap between these two numbers, 1.3 and 0.05 as estimates, just look at the complexities of thinking about data such as this. So the ICMR third survey, as far some part of it has been leaked, and maybe people on this panel have actually seen what the results are, but what has been leaked suggests about a 25% seroprevalence across the country. And there have been other estimates that suggest 60%, 65%, we're already at herd immunity. If you believe 25% across the country, then it's very far from herd immunity. But it's not clear what that number is and what the details that go into that number are. The only lesson that I sort of want to make is that you should be a little wary of ecological correlation. As I said, exactly for the reason that I described. One does need better data, and one needs consistent data. One needs to understand why surveys can give you such different answers. I think what's very important is the role of the young population in India, Pakistan, Bangladesh. Remember that the median age in India is about 28 point something, Pakistan and Bangladesh 22, 27, etc. And this disease disproportionately affects older and younger people. And the nature of course, the other types of comorbidities is also important. What seems to be interesting about India is this particularly large asymptomatic fraction. And that's something we really need to understand and try to figure out. But as I said, I mean, none of this is really should take away from this clever idea that there is something that the hygiene hypothesis might underlie why overall Indian mortality seems to be less. All I want to do is sort of nitpick around the edges to say that, look, there are some numbers we need to understand better, and we do need to understand the sort of physiological and clinical implications of ideas such as this. So let me just stop sharing at that point, and thank you.
Okay, thank you, Professor Gautam Menon, for that very nice comments. And then now can I go to Professor Gandini Kang, and what does she think about the talk and her comments on the hypothesis? And as she said, she's the most experienced person on the topic here, like the real person who works on that. Yeah.
Thanks a lot, Shekhar. Thanks a lot, Gautam, for that. So let me just make 3 points. One is to say that if 25% of India has indeed been infected, as the ICMR claims, which I think they're right, by the way, that is 300 million Indians infected. So infection is not disease. So there does seem to be a difference, speaking to what Gautam said, that we do have a much larger proportion of asymptomatic infections, and we don't understand why. And that also, if asymptomatic infections protect, which you expect them to do, then the hypothesis that is being proposed by Shekhar and Rajeeva might actually be true. So now we come to what do we think is happening? SARS-CoV-2 is a mucosal infection when it starts off. Mucosal infections are ones that, by the nature of the lives we lead, we are exposed to all the time. We keep seeing them. We start to see them in very early life, and they happen repeatedly. The first time, second time, when you get these infections as children, the first time, third time, you get even less sick, and over time, these infections become asymptomatic. So we've done some work that has looked at what happens with early life mucosal infections. And essentially, the more mucosal infections you see, the higher, whether they are with symptoms or without symptoms, the higher the level of inflammation. So in children who live in slum areas versus doctors' children in Vellore, we've published this data. You see fewer pathogens, not no pathogens. We're not as clean as the West. You see fewer pathogens, and you see less inflammation in upper socioeconomic groups, and you see more pathogens and more inflammation in lower socioeconomic groups. But if you follow these groups over time, what happens is after a while, every infection you're acquiring is asymptomatic. So you are getting protected from these mucosal infections. So I think the hypothesis is one that is really interesting. Now here we have a pathogen that's a new pathogen. And you wouldn't expect for people to have prior immunity to that pathogen. We know we don't. Is it possible that recent coronavirus infections could help you get some level of protection against this new coronavirus infection? We don't know that that is the case, but it certainly is something that we can investigate. So if we were to take age stratified samples from individuals who are asymptomatic or who present with respiratory infections, could we look at the proportion of those infections that are seasonal coronaviruses? Would we see a different picture from the picture that is seen in the West? If we did, then that would give us partial support for this hypothesis. The second component is around severe disease and why do you get severe disease? Coming back to my story of inflammation, this is an inflammatory response. So if you are going to have a situation where you have been in effect tolerized by having your immune system inflamed so many times that when a new pathogen comes along, you no longer make that massive inflammatory response. Again, you have a situation where you might have support for this hypothesis. I think ecological studies are fascinating because they use lots of data. It's easily available data, and it allows you to make a hypothesis. And then you can go out and figure out, okay, which are the biology components of this hypothesis that I can actually test. So I think what we have here is a very interesting premise. There's nothing to say that it's wrong. There are clues to say that it might be right. And I think we should go out and do the studies.
Okay, thank you, Professor Kang. So I think I have we don't have a lot of time. I'll have to take some questions from the audience also, but I want to at least, go through one question from each of the panel, quick response, I would not say a rapid fire, but then like a thing. So I'll go back from Professor Kang and then go to the rest. So this is probably the elephant in the room, I guess. Are we going to have a second wave? So
I'm actually really worried about the variants. From the data that we are seeing from South Africa and from Brazil, and I have lots of questions about the Brazilian data. But the South African data, South Africa is a country that has much more robust surveillance systems than we do, the right kinds of partnerships. And if they are being as badly affected as they are, I really want to understand more about the variants and the ability of the prior immune response to protect from infection or disease. There was one very interesting piece of data that came from Shekhar Mande last week for the Novavax study, where essentially they showed that in people who were previously seropositive and were then reinfected or infected after being seropositive. The rates of infection were the same in seropositive and in seronegative individuals. So that tells you, so if 2% of the seropositives got infected, 2% of the seronegatives got infected, you would have expected seropositives to have some level of protection. That was not seen. The problem is I haven't seen the data myself, so I don't know whether it was infection and disease or infection alone. Because if it was infection alone, I'm less worried. If it was infection and disease, I'm very worried.
Okay, so now got Professor Menon. What do you?
I agree with Gagandeep. Variants are very worrying, and especially since they seem to have much larger R than the original wild type virus. But I can point out where we've been wrong once. I think most people expected that the puja season, essentially the festival season in the north around November would have been a point at which cases would have risen. We didn't see that in mortality. We didn't see any sort of inflection in cases at that point. Maybe Gagandeep, I'm very interested in knowing what Gagandeep has the interpretation of that. But cold weather, people together in enclosed spaces, relaxation and mask wearing after several months of lockdown. Why didn't we see this increase is something that was really interesting to me. So since we've been wrong there, I'm not it would be dangerous to commit to saying we would definitely be a second wave.
So just a point to add.
Gautam, I also wanted to comment on, I didn't do that, about the variation in the data that you saw in Karnataka. With sero surveys, the assays are a problem.
Yeah.
You need to use the identical assay to be able to compare results.
Yeah.
And we haven't seen that. I know the assay that was used by the CMIE group, and that's a very, very good, very sensitive assay. I don't know the assay that Giridhar Babu and colleagues used.
Yeah, thank you.
And if you hit 40, 50%, you've got your explanation for why you didn't see cases.
I would just like to add one more point to Professor Menin's thing. I mean, also the farmer protest that is happening right now outside of Delhi, I don't see any masks, and usually I see many people who are quite middle-aged, or I would say old, and they are flocking in, I don't know, thousands, and so yeah, definitely things have not.
Although the one mitigating factor is that it's outside.
Okay.
So that's the only mitigating factor.
Okay.
I'll just share the air sampling study that CSIR has done. We have sampled air in many different locations, in ICUs, in patient wards, in open, in closed rooms, in people in which 6 people in a family were infected with the virus at a time. So all kind of very extensive air sampling work we have done, both in CCMB and IMTech Chandigarh, and results are very fascinating, and it clearly shows that, of course, results are on the expected line, that masks reduce the risk by something like 90%. So it's huge. And in the houses, the virus actually stays on in areas like toilet and all for even 2 hours in air. And the dead bodies don't carry virus. So dead bodies, the current practice is that they are given in sealed envelopes. That practice actually is not rational. Even dead bodies is given open. Dead bodies actually don't have any virus around them. So the things like that, actually the things are very interesting. But closed spaces, of course, more dangerous. Open spaces are much less dangerous in terms of transmission.
I would like to have one final comment from Professor Karandikar. He has been part of this work, and then we have this additional question of what about the second wave?
So about this, of course, correlation does not mean causality is something I teach all my students, and thanks Gautam for illustrating it again. And the Simpsons Paradox is of course extremely important for people to draw any conclusions of this kind. So the paper is just a plausibility that it may be supporting hygiene hypothesis. Of course, not claiming that this proves hygiene hypothesis or anything of that kind. Number one. About second wave, I will not say anything. I mean, I only look at data about which there is no data, so I should keep my mouth shut. But Dr. Kang and what she said, Gagandeep said, I mean, we are worried, but hope that it won't happen.
I would just now take a couple of questions from the Q&A that has been posted. So anybody who wants to answer can actually answer. The one Sonia asked, how do we know anything about the diversity of coronaviruses in India? Apart from hygiene, is it possible that a high diversity of viruses contributes to protection? Professor, who would like to answer that? Professor Khan, probably? Is that?
I think Shekhar would be better.
Sure. Okay, go ahead. Yeah.
Because IGIV is doing a humongous amount of sequencing, probably more than many other institutions.
So
CCMB.
We do see all kinds of diversity in India. In the clades which are A3A and A2AI and all those things, they seem to be more prevalent. What we saw in the beginning of the pandemic, that was very quickly taken over what was called a D614G, but it happened worldwide and also happened in India. And then over a period of time, the 614G actually became more prominent. We also do see the UK variant to some extent, but it has not spread as much as what it did in UK. So, which is interesting. The UK variant, of course, is 17 mutations, all of you know. The most prominent of that is N501Y, but it is also a double deletion at 66, 67. And a double deletion actually makes the spike protein, which in the early stage has to open up before it binds to the receptor. It actually makes it more open. So we do actually see diversity of all kinds of strains, and that does not actually really explain why we don't have so many asymptomatic infections.
Okay. Yeah, thank you for that. We have actually one question from an undergraduate student from IIT Go. So he asked, is it advisable to take the vaccines available right now, or should we wait for them to put up the results after vaccination?
Okay, so I have been a very strong proponent of vaccinations. I would just like to say this, that both the vaccines which have been approved, emergency approved, are shown to be safe. In fact, more than 1 million people now have been vaccinated with both the vaccines, and we have not noticed anybody dying because of the vaccine. So they are safe. Both the vaccines are known to elicit.
Shekhar is frozen.
Yeah.
I was wondering, is it me or him? So yeah.
Yeah,
are known to elicit good immune response. So it is so intuitively anticipated that it does offer protection based on at least the safety and the eliciting strong immune response.
Okay.
So I'm a strong proponent of vaccines as well. I've spent, my entire professional career working on vaccines, and I think vaccines are going to be a big part of our way out of this pandemic. But in terms of the data that are available, both vaccines are safe, both vaccines are immunogenic. The immunogenicity data for both vaccines has been published. There is data on clinical efficacy in humans for one vaccine, and there is animal data for efficacy on the other vaccine. So we hope that both vaccines will be effective, but at the moment we are awaiting phase 3 data for one of the vaccines.
Okay. Yeah. Thank you everyone for this bright discussion with kind of, opposing views and still kind of agreeing to be.
It's not opposing at all. I think we are on the same page. It's about how much data is currently available. And, I think we are going to have lots of good vaccines. These are early days. And we have full data for one vaccine. We have almost full data for another vaccine. We'll get data for many more vaccines. Whatever it is, vaccination is a good thing.
Vaccination is an important thing, not only a good thing. I would like to urge everyone who's listening to please do get vaccinated when your turn comes. It's important.
Okay. Okay. Yeah. Thank you very much. So we are 5:01. So just we are right on time. And then I would have loved to ask many more questions, and there are many more questions in the Q&A as well. But our time is over. So thank you everyone for joining this webinar. I would like to specifically thank Professor Sudhir Krishna from NCBS, who actually enabled this panel to be here and to have this discussion. And also special shout out for Pavitra from NCBS, who actually organized the entire webinar, and she was very good at handling different emails and different requests from me and others. Okay. Thank you very much. So we will continue to look at the COVID pandemic with more vigilance and with more knowledge all of us have had due to this webinar. Thank you very much.
Thank you, everyone.
Thank you, Srinan.